Good afternoon and a warm welcome to everyone. This is we are Medgenome, the leaders in genetic diagnostics in India. And today's webinar is again part of our ongoing series with FOGSI on genetic education from laboratory to bedside. And today is the fifth webinar, and this is the first part of a two-part webinar, which is laboratory genetics, test ordering, and interpretation. So the program for today is on starting with the introduction to the series by Dr. Mandakini, and then followed by our welcome address by our chief guest, Dr. Basav Mukherjee. And we have two talks lined today. So the first one is by Dr. Hema Purandari on cytogenetic techniques, fish and karyotyping, and then followed by Dr. Prajna Ragnar, who will talk to us about MLPA and QF-PCR. So before we start the session, I wanted to inform the audience that if you have any questions or comments, please use the Q&A window of the Zoom interface, and we will be sending out a recording of this in another week or so. So without any further delay, I would like to request Dr. Mandakini Pradhan to introduce the series and start off the session. Over to you, ma'am.
Yeah, thank you, Joseph. Good afternoon, everyone. This is our series of genetics and fetal medicine webinar, and that is from laboratory to bedside. And FOGSI, I thank our president, Dr. Santakumari ma'am, and all vice presidents, specifically Dr. Fesi Luis, who is in charge of genetics and fetal medicine committee, and then Dr. Basav Mukherjee. Whenever I have requested them, they have joined us to encourage us to do this type of a webinar, which is little difficult, not the usual ones, because it involves genetics and everybody may not be interested in genetics. As I always tell, that next 5 years down the line, probably our day-to-day practice of obstetrics and gynecology will change onto the knowledge of genetics. Lot of things, lot of investigation will be, even including the therapy, will be based on genetic analysis of a person. Hence we aim to do a series of seminar, and this is the third of its kind, fifth of its kind. We always wonder, as an obstetrician, we always wonder, what do I write? Fish, QF-PCR, some laboratory will say, no, we don't do fish and we do QF-PCR, and we are really confused. And then to add on to it, once we start with fish, by the time we realize that fish, we have understood what is fish, then next we go on to start listening to terminology like MLPA. So then we get more worried. So probably today's webinar will highlight this and make us learn what is this basic genetic tests. That is, these are two in series, and first is karyotype and fish. The next talk is QF-PCR and MLPA. These are all terminology that are technique that are being used, and there are big people who are talking on it, and I'm really thankful to you. Next, Joseph, next, can I introduce Dr. Basav?
Yes,
Yeah,
ma'am.
I welcome Dr. Basav to this webinar with from his busy schedule of practice. Definitely he is very busy, and being vice president of FOGSI, it is one of those posts which get lot of responsibility and lot of busy for contributing to the society. Dr. Basav is a consultant gynecologist in Kolkata. He has various innumerable responsibility in FOGSI in different capacities. One can see onto it every time, and probably he highlights that people from Kolkata are very meticulous in their work. That they are so meticulous that every conference highlights it, their meticulousness, and I have learned many things from him, that type of a meticulous this thing. If I am in FOGSI, like Dr. Basav is one of them who have pushed me into FOGSI and have encouraged me to enter into this something FOGSI which I was not very keen on it. My association with him goes long back, but then I am thankful to him to agree to come and join with us, bless us, and take this webinar forward. Over to you, Dr. Basav.
Thank you, Dr. Mandakini. It is a pleasure to be here. Dr. Mandakini is a strong, silent, yet dynamic and a very talented chairperson of Genetics and Fetal Medicine Committee of FOGSI. And it is FOGSI's pride to have her here with us. And this is a series, I understand, of 5. This is number 5. I think, I'm not sure 5 of how many, but of webinars on genetics.
Total of 7, Dr. Basav.
5 of 7. And so whether it is studying for MRCOG, whether it is in MBBS, whether it is in practice, genetics is always generally confusing for most of average obstetrician and gynecologist. And I understand the series is to try to make sense of the part which we do not understand. As she rightly said, I think when you order tests, you need to know what exactly is happening and why it's being done. I am sure that at the end of the 7th series, if they can come up with a booklet or some sort of a compilation of the thoughts of these talks which are going on, that would be of immense use to all the gynecologists, and maybe at AICOG Indore, you can use that and spread it around, because a lot of people would definitely be interested. I'm sure the education partner MedGenome also would be interested to get this knowledge passed across to a lot of people who are not connecting now, who think it's only for geneticists and fetal medicine specialists, yet would be needing to know, have a basic knowledge of genetics, which Dr. Mandakini rightly said, without which it will be, it's just an invariable inclusion to our practice, which we will be gradually seeing with time. So thank you very much for having me. I don't want to come into the academics. We have wonderful speakers. Dr. Hema Purandare is legendary, and Dr. Pragna, we will look forward to hearing from them and to learn more about the subject. Thank you, Dr. Mandakini, and all the best for happy academics over the next hour.
Thank you so much. And to inform you, yes, we have discussed about taking out this booklet and having some amount of know-how or what to do in genetics when you are in, like, say, recurrent abortion, then something like that. So we are trying to do that, but then what you have done is you have posted me to AICOG Indore. So
I'm sure MedGenome also, Mr. Joseph, will be very interested, because this will be a publication which will be from FOGSI, and MedGenome will bear the costs, and then at least there will be a lot of dissemination. You can start it at the managing committee, 250 people, but then again, there'll be other people also who will be interested, a soft copy and a hard copy. But it's so important, and you're doing so wonderful work, Dr. Mandakini. I think it's important that it reaches out to people. People will not understand everything, but just some very basic things or practical needs which you need, as you rightly said, in RPL, in a miscarriage with a viable fetus, what exactly you need to send for, what exactly is happening, the various tests which are done, and some interpretation about that. It's so important, yet so unknown, and yet a lot of people haven't joined here because they're not very sure what to get out. But I'm sure if you can compile it, there'll be lot of takers to understand the very basic things which are so important for us to know. Thank you, Dr. Mandakini. Thank you.
Thank you for that. Okay.
Okay, so we'll continue with our program. So I think our first speaker for today is Dr. Hema Purandare. I now request Dr. Priya Kadam, if she could introduce our first speaker.
Yeah, thank you, Joseph, and thank you, Dr. Mandakini and Dr. Mukherjee, for giving us this opportunity and for being here. We have 2 excellent speakers today. Dr. Hema Purandare, as Dr. Mukherjee rightly said, is legendary in the field of genetics, and like one of her previous talks, she told us she's been in this space for more than 40 years, and we all have a lot to learn, and we are learning from her. So just as a brief introduction, she's the founder of a Center for Medical Genetics in Mumbai. She has received her genetics training in USA, UK, Europe, Singapore. She is, of course, a certified genetic counselor. And what is very interesting about her is the rural genetic counseling centers which she has set up, and which provides or disseminates this knowledge to where it is needed in all different areas. And she has several achievements to her credit with Chaturashtra Chatura, Bharat Jyoti Award, Indian Achievers Award for Health Excellence, Wonder Woman, and many of the national and she's a member of many of national and international societies. So I'd actually like to invite Dr. Purandare to begin her talk. And also thank you all participants for joining us. Some of you might have attended all other sessions, and we look forward to a great one today.
Over to you, madam. Madam, you can share your screen and stuff.
Thank you, Dr. Priya,
Thank you
for this kind introduction, and Dr. Mandakini and Dr. Basav. I think the idea of having a booklet of this this conference meeting, whatever educational program is going on, really will be very helpful, because most of the times when the newer tests are introduced, I have seen in practice that people want to jump at the latest test without understanding that there are some tests which are there are some conditions where basic tests are also very important. But if you look at the incidence of the genetic disorders, chromosomal abnormalities are the most significant and common cause of genetic disorders. Starting from preconception, where 10 to 50% of the gametes can have some kind of a chromosomal problem. Zygote, embryo, and fetus, if you look in this early part of pregnancy, 50% of first trimester and 5% of late trimester abortions and stillbirths have a chromosomal cause as their pregnancy wastage. In children, 1 in 65 or 0.662%. In live births, you will find. So it could be just at the neonatal or in a pediatric stage little later. Various types of intellectual deficiencies may be seen later. So these are like 1 in 0.62% in pediatric cases. 0.5% to 1% are balanced translocations. That means these people are carrying chromosomal abnormality, they do not suffer, but chances that will be passed on to progeny in the form of malformations of pregnancy wastage is very high. Most important thing what we have to remember, genetics is not now related only to obstetrics or fetal medicine, but all the areas like pediatric, ENT, oncology, orthopedic, endocrinology. More than 40% of the cases you will find that the cause is because of the genetic disorders, chromosomes being the most. And therefore, but fortunately or unfortunately, all the cases which we see in the practice are coming through obstetricians. So if there is a previously child with deaf mutism, so you will not get a reference from the ENT specialist, but they will come to the obstetricians and then they will ask, we want to plan a child, or previous child is like this, and then we have to do entire workup. So what I'm trying to say is that obstetrician is in the key position of prevention of these disorders, and absolutely all of us are on the radar because of the availability of technology. Now, human chromosomal abnormalities are high in early miscarriages. There are various papers on this, and this particular paper, which is mentioned here, given the reference, that aneuploidy contributes greatly to pregnancy loss, and cytogenetic tests should be offered first if the couple would like to find out the cause. Then the maternal factors are to be ruled out as well. But if you see in the table on the right hand side, trisomy is like, now we classify that into with embryos and without embryos. And if you have a products of conception with embryo, about 42% are, this is one survey, 42% are showing the trisomies. Then monosomy is in 16%. But if you see the left hand side column with embryo, the incidence of chromosomal abnormalities is higher. Also in IVF, now this reference I came across, though I have not gone through it completely, but chromosomal abnormalities are present in more than 90% of IVF embryos, and even those produced by young fertile couples. The mechanism needs to be understood, but I think again we can go through the reference. Now, knowing about so much of pregnancy wastage, we have seen that the percentage of babies which are born is after a lot of efforts of losing so many pregnancies. But then for that, the chromosomal disorders and tests are required. So what are these tests? Now, chromosomal tests can be done on any body tissue. Mainly commonly used are blood, bone marrow, products of conception, or prenatal tissue samples. They are constitutional and lifetime. But in hematological conditions, these are acquired and there are a lot of changes at various disease stage. So it helps in diagnosis, remission, and relapse, and of course the prognosis. Chromosomal disorders affect multiple organ systems, so all clinical specialties are involved. Hospital admissions are frequent. High complexity tests and skilled staff is required because it is entirely a manual work. So if you are going to analyze one patient, the karyotype of one patient, you want to do it. Every individual technician has to handle one or two manually the samples to give you a karyotype. Turnaround time of the report is 10 to 15 days, and most of the results apply to patient and family. Opens various reproductive options. Today, available methods for chromosomal studies are chromosome fish and microarray. We have a separate talks on microarray. But about chromosome fish, if you see comparatively, so for chromosome, you require again cultured cells. In fish, you require cultured and uncultured cells in metaphase and interphase stage. And microarray can be done on DNA samples, so which is more stable for transport also. Now, resolution in chromosome is about greater than 5 MB. Need now in fish you need prior knowledge of specific region. Of course, in microarray again compares hybridization intensity between patient's DNA and normal controls. So it's only for the fish that you have to have a special knowledge of the region. Turnaround time for chromosomal analysis is 2 weeks. Results are accurate, and in priority cases, urgent cases, after 72 hours of harvesting, 4 or 5 days we can give provisional reports. Of course, the fish will also take 2 to 3 days, and turnaround time for microarray, this cannot be shortened, which is about 2 to 3 weeks. The diagnostic yield is increased by 10% in unexplained developmental disabilities and congenital anomalies. He can detect mosaicism again fish, but mosaicism in microarray, you have to be very cautious. That is less than 20% are missed by chromosome micro. I'll be showing all case studies also in this respect. 20 metaphases are studied for giving a correct report. Large number of nuclei are required for fish report. And another thing about microarray is that it cannot detect balance rearrangement. So whenever there is a chromosomal abnormality, you need to have the balance rearrangement detected if you have to give the recurrent risk. Then it provides reliable information of gains and losses. That's the biggest advantage. But again, like ring chromosome, isochromosomes, dicentric chromosome also, there is a little drawback. The system is called ISCN, where there has to be one international system how the reporting is done for precise chromosomal orientation and discrete changes. And we can move on to the next slide. Now, report format. Now, any laboratory will have the standard report format, but as per the accredited labs, you have to give what is given in the first column. The same is applied for blood, CVS, amniotic fluid, cord blood, bone marrow. Important factor is that indication. Now, the traceability, the referred by when we give this SID or the sample ID or order ID, it is mainly for the traceability of the samples. Now, indication is very important because clinical correlation, because many times lab receives sample, just do karyotyping without giving history. So we should make an attempt to see that you provide all the history to the lab so that they can give you better answer. And collected on all these cells analyzed as per the guidelines. Again, same chromosome can have a different interpretation, as you can see in this slide. Suppose if it is karyotype, like in a pediatric case, the most common what we do is for Down syndrome. Now, if it is extra chromosome is present in the form of translocation 21, for the child it will be same clinical significance, but the recurrence risk is parent is carrier is very high. So in pediatric report, you will always advise that parental karyotype is required, because otherwise 100% they are carriers, 100% babies will be Down syndrome. Now, prenatal cases, again, consequences, because it's very critical and they have to take a decision of continuation and termination of pregnancy, which is their call. Then again, involvement of other systems, because they will always say, if child is born with a disorder, what can happen? So I think we are supposed to give them this advice as well. In high-risk cases, if they continue the pregnancy, we also have to advise them place of delivery that it should be at a tertiary care hospital. In abortus, their first question patients is that why did it happen? Of course, cause and advice for then we what is the cause, and we advise further tests also, and on the tissues as well as parents. So if you are doing karyotype, you feel that you want to do microarray, you are not getting it, then we store the DNA of these tissues. That's a very good thing which can happen, and the samples can be stored for a long time. There are disclaimers on the report, but we should explain to the patient when you are taking the sample. For example, if there is a prenatal report, our disclaimer will be this is a provisional report of numerical count or specified chromosome. So patient should understand what test they are doing and what would be the limitation. And of course, fish results must be confirmed and supplemented by fecal karyotype, and no irreversible action should be taken, however reliable the report may be, more than 97%. In prenatal karyotype test report, reliability of the test report, but also to be explained, minor structural anomaly, microdeletions, duplications, certain chromosomal rearrangements, single gene disorders, low-grade mosaicism, or any other birth defect is not detected by karyotyping. So when they come for karyotyping, it's not that when you get the karyotype report as normal or abnormal. So we have to tell them there are many things which can be, which are not mentioned. And again, at the time of counseling, when you order the test, this should be explained. Standard disclaimer on every sample, of course, these we give it on our reporting formats, but if the patient is told beforehand, they will also know what test they are going to do and for what. Otherwise, internet may not provide them good information. Now, can we show the previous? The standard comment for us is that analysis is based on sample received in the laboratory. So that's very, very important. We can go to the next slide. Now, chromosomal abnormalities are classified as numerical or structural. Aneuploidies, triploidies, aneuploidies, extra chromosome, triploidies, extra set, tetraids. There are two sets. Mosaic is mixed cell line, and structural are deletion, ring. We will be seeing again that. Then translocation, insertion, isochromosome, inversion. So the terminology explanation needs to be written in the report. Autosomal and sex chromosome, we are all aware of the syndromes which are easily detected by chromosomes, from Down syndrome to also Philadelphia. Then sex chromosomal abnormalities, if you want to know, then these are Turner, but you have to be very cautious about Turner syndrome variants to give them what will be the consequences of their syndrome, or what is the likelihood of their achieving menstruation or pregnancy. Again, Klinefelter, triple X. So all these sex chromosomes that we mentioned here, will be giving you the examples of that. This is just a pictorial form of all the abnormalities, as you can see here. Also, there is another syndrome called as chromosome breakage syndrome, but this falls into hematological category, but this is also possible by chromosome analysis. Fish we all are aware of, and aneuploidy, you always refer a case and always ask for fish report first. As you can see, if there is trisomy 21, then you can see those three red dots. Similarly, SRY gene for testicular, like testicular determining factor, SRY gene is the principal factor in male differentiation of the sex organs. You can see those two red dots where that is the SRY region. Or I think it came in 1999. Until then, we used to give only XY reports and male-female differentiation. The down you can see these colored chromosomes. So when microarray was not there, differentiating marker chromosome, as you can see on left side karyotype, that marker chromosome we had to identify to find out whether it is pathological or not pathological. And hematological malignancies, most of the malignancies hematological are specific chromosome, but 922 chromosome translocation, this is a fusion gene, though this is not the a topic for today's talk, but just to give you an example. So this results in activation of tyrosine kinase, leading to discovery of inhibitor drug Gleevec, which is highly successful treatment for chronic myeloid leukemia. So extremely useful technology in chromosomal technology in cancers, blood cancers. Now, what does the test result mean to a patient? That is most important, and who should interpret the results? Primarily by a referred lab. Referred lab should be accredited and signatories. Referring physician interaction. If referring physician is going to tell the result to the patient, then interaction with the laboratory to understand if there are small things to be understood. Otherwise, they may not be that knowledgeable because they are not from the field. Then medical geneticists, certified genetic counselor or fetal medicine experts are the best. Aneuploidies are straightforward to interpret, extra chromosome and the consequences. And if whenever karyotype is normal and abnormal ultrasound findings are there, microarray is advisable. Then deletion, duplication, translocation can cause myriad of health and developmental issues. It depends on what genes are missing or present in too many copies. In prenatal diagnosis, it becomes very difficult because phenotype of the fetus is not seen that well, because in a child is in front of you, you are able to correlate it better. But for recurrence risk, you have to do parental karyotyping opinion. As opposed to that, inversions can have bad consequences as there can be no consequences. So like I'll show you that slide too. Expression defects are also tissue specific like Pallister-Killian syndrome. So it is tetralogy of a PR of the chromosome 12, and in that it will not be seen in blood. So if you are going to do blood of a born child and there is diaphragmatic hernia, some clinical syndrome, you will completely miss it out. It comes only in fibroblast culture. And we have to also mention about implications, clinical correlation, and additional tests will required. Sending the sample the right way is the most important thing, because if you don't send sample properly, the tissues can get degraded or it can get contaminated. So lab should give you provide these specimen tubes. So tissue and test tubes and temperature. Most of the time, luckily, the samples which are sent for genetic analysis are at room temperature. Timing and transport territory. You have to consider local holidays when you are sending the samples, because otherwise it will lie in the cargo and you may not be able to get the samples, and samples again can get deteriorated. Information required labeling, all of us know patient's name in the cell. Many times it is maiden name on the report and married name is on the tube. Age, sex, all these things are to be carefully looked into. Clinical information relevant to genetic tests, family history. You may not be able to take family history for 3 generations, but at least obstetrician should make an effort that if there is any family history, so which may add on to the indication. Clinical notes, relevant reports, consent forms, of course, are required. Sample collection and transfer criteria are specified by the laboratory. Normally, we provide this kind of information and instructions to the referring doctors, and must contact chosen center before collection of the sample, because you may have certain criteria which the laboratory wants or may not be showing standard, because many days for karyotyping we get sample in detail. So that is not so. So such kind of information will be useful. And now contacting is an enclosing reason for referral, informed consent, and patient history. Once again, I would like to repeat that. Now, choosing a center, you must see, because you may have a center which you like the most, but personnel, the team, and the equipment is important. It is not only the equipment, it is man behind the machine is very important. Licensing and accreditations, range of genetic testing and counseling services, report interpretation by medical geneticists or the experts which I mentioned, communication with referring physician, so that that report is just not coming by email or post. If it comes, you should be able to contact a referring physician. Turnaround time, logistics, report reliability, and facilities under one roof are preferable. Why am I saying so much? Because you have to remember that we all abide by law, we all know all the rules we will follow, but the legal advisors or the lawyers are going to find out some kind of or the other faults in it. So what will they look at first? Decision to offer a testing. Is it correct? Was it correct? Was it related to history? So this is the referring physician's responsibility, because the lab will do what you order. Pre-test counseling, choosing the test, and again timing is everything. Let's say you want to do CVS or you want to do amniotic fluid. The center I mentioned about it, what it will be, testing itself. If it is a prenatal procedure, and the of course laboratory, but prenatal procedure also again time constraints. Well, luckily we have got legal limit extended, so testing itself can be delayed, but you will have little time to discuss with the lab. Informed written consent must have read and understood the test in language patient understand. In Mumbai, of course, we do Hindi, Marathi. Most of the times we'll be able to do Hindi and English. Post-test counting results and also must include follow-up advice. Was this given to the patient? That will be the first question. So keep your documents very safely. Now, indications in different stages, pre-test, post, at puberty. So pre-test will be right from ultrasound marker to facial dysmorphism, ambiguous genitalia, pituitary wastage, developmental delay, so on and so forth. In puberty, it is short stage primary amenorrhea, gynecomastia, absent or poor secondary sexual characters. Adults, it will be prenatal infertility, repeated pregnancy loss, infertility, oligoazoospermia, and sperm parameters. We will do some case studies now. Bad obstetric history. In bad obstetric history or any history, there is great importance of genetic history taking. 3-generation history pedigree is essential. The risk may differ because if one patient is seeing you for the first time, everything happens good, there was no history. By the time she comes to you second time, again you have to take a family history because you might have somebody, she might have somebody who had delivered in the family, in blood relation, who had abnormal child, which was not there for the first time. So we cannot go by what was given before. Personal family medical history at each visit needs to be there for refresh as additional new members I told you can add. Ethnicity, maternal age. Maternal age is important for dominant autosomal dominant condition and if couples are carriers for any disorder. In bad obstetric history, we have products of conception as well as parents. So autosomal trisomies, if you get miscarriages, you find minimum embryonic development. Spontaneous abortions, you will see 13, 18, 21. Trisomy 16, it may be localized mainly to because of placental causes, placental insufficiency. In 45, it's most common in early abortion. Triploidy, IUGR, hereditiform mole, some symptoms are like syndactyly. Unbalanced translocation, developmental delay, and dysmorphism. Now you will see various types of chromosomes you can get in products of conception. Multiple abnormalities also can be there in products of conception. You can go to the next slide to see what is the importance of history taking. Now this case came to us when she had a history of first child loss or terminated because of diaphragmatic hernia and echogenic kidneys. Second time she came to us with a slightly, she was early in pregnancy and we took the family history. No history was given, but the fetus which was there in first pregnancy had inversion of X chromosome. Now karyotype of husband was normal, wife was normal. We thought let us take family history which was not given. But when we took family history, the lady did not give her husband called us later and said that her brother is slightly intellectual deficient and not ready to agree. And the family is not agreeing to this that he is slightly backward. Now karyotype was done on that child boy who had intellectual deficiency. Luckily they cooperated. There was inversion X. His mother also was having inversion X. Now because females have inversion X will not have symptoms because there is a second X to balance, but male having inversion X can have intellectual deficiency. They came in the pregnancy when she was pregnant, prenatal diagnosis showed abnormal results. Second baby was affected. So there are some reports also in molar pregnancy. If there is no chromosomal abnormality, rest of things we have discussed last time also. But maternal mutation studies should be done because these are associated with familial recurrent hereditary mole. Parent with two types of chromosomal abnormalities you get. Parent with a chromosomal translocation or parent with normal karyotype but abnormal baby having chromosomal abnormality. Now differences are in child is also having reciprocal translocation like parent, then child can be normal, but they will have further chances in their when they become parents, so that will be transmitted though not affected. Report can be totally normal, or there can be irregular deletion or irregular, that is in the form of deletion or duplication. Then you may get a result of abortion, congenital malformation, or child may have intellectual deficiency. So you can get normal, you can get carrier, or you can get affected. In Robertson translocation, we know 21-21. All pregnancies will be, so that 2 21s will always go together. But it has to be a homologous chromosome. So there is a possibility, recurrence risk is 100% and donor is to be advised. Now, parent with normal karyotype chromosomal rearrangements in the products could be de novo or due to gonadal mosaicism. In inappropriate genetic counseling, I just want to give this example. Again, this family came to us when the lady was pregnant, Mrs. A, in 15 week of pregnancy. Her previous child had multiple congenital anomalies, no evaluation done. parental karyotype was done, husband was carrier, wife was normal, as you can see 46XX. And they had another child in spite of being karyotype with chromosomal abnormality. Now, when I asked her, why did you do this? Why did you not do prenatal diagnosis? You have come now. So she said, no, when we went to our doctor, doctor told you, see, there is a balanced translocation in husband. You will not get any affected child. That was just a chance occurrence. So unfortunately, they had to pay the price for not getting proper counseling. So it's very important that if one is not capable, you should go to a referring geneticist, refer to geneticist. Complex rearrangements also have got similar kind of rearrangements can occur, but the chances of multiple miscarriages is more. This is a case where now again this case is very interesting, very recent case. Three first trimester abortions and three babies with cardiomyopathy consanguineous marriage. Now karyotype was done elsewhere was normal somehow, and somehow my mind was not ready to accept karyotype, or because there was a history of three first trimester abortions. I said I would like to do karyotyping again. And we did karyotype and we found that there was 1122 translocation. The importance is you evaluate, give advice, do any of the required NGS tests for cardiomyopathy, but this lady will additionally also have chromosomal abnormality. So if you are doing any kind of high end test, chromosomal studies is a must. Now, in wrong sequencing of tests, now you can see in this type the same thing happened because higher tests are available. Tendency to jump to the higher test before doing regular karyotype is there, though it is more expensive. Karyotype is much cheaper as well. Now, 32 weeks IUFD, this case was directly referred for microarray. Couple came to us, microarray report was normal. Microarray report was normal, and we suggested since karyotype is not, let's do it. And husband was translocation carrier, so the husband is translocation carrier. Now, if we would not have asked for karyotype, they would have landed up in microarray would keep coming normal. But as I explained, reciprocal translocation concept. In prenatal diagnosis, it is most critical. We know all the indications, but the most common is for chromosomal abnormalities. In chromosomal abnormalities, I mean, this is the most common cause. If you will all agree with me, that most of the referrals, more than 85% or 90% are for doing Down syndrome abnormality, for ruling out Down syndrome or any other. Lot of screening methods are there. Morphology of the cell has to be good in CVS, and as shown in the dish, you must have good villi which are transported. We have to ensure that maternal cell contamination is not there. The tests are done by taking testing in two flasks, so that we flask A and flask B, or tube 1 and tube B must match, and different analysts should analyze the samples. Why I am talking about the tissue is there is a mischromosomal disorder, a syndrome called as Prenatal syndrome, where there is isochromosome 12p, which I mentioned earlier. Fetus will IUGR and diaphragmatic hernia, which is detected much later, not early. You can also have trisomy 18. But this kind of Prenatal syndrome, if you have, because it is late in pregnancy, fetal karyotype, one is tempted to do fetal karyotype by cord blood, and the report will give normal results because this chromosomal abnormality expresses only is in fibroblasts, so amnio is more reliable. Therefore, all the time I'm saying that you must have communication, give your reports to the lab, talk to the consultant so that there is no mistake happens. Now, we are aware of mosaicism, so fetal mosaicism and placental mosaicism, or both can have same abnormality. There can be complete feto-placental discordance. So various types of mosaicisms are mentioned here. But what can happen in the report? Because we don't know if you're doing CVS from where the needle has gone. Sometimes maybe the needle is passed through the mosaic area of the placenta. Now, in this particular case, karyotype was 47 and there was 21, plus 21 and plus 720 also abnormal chromosome. Now, 720, these kind of chromosomal abnormalities usually are not significant, especially when you are going to take a CVS sample. But you have to follow it up by amniocentesis. Now, in this case, the patient decided to terminate the pregnancy, and products of conception showed that it was 21. So, probably a mosaic section sample had come. Now talking about MTP, what the law demanded. Now this case came for hypoelastic nasal bone, 19 weeks. Karyotype for fish was normal, karyotype was normal. But in prenatal, we found extra chromosomal segment on chromosome 9. Now, if you would have said like today, the tendency that whenever you have got a molecular indication, the obstetricians order fish and the required molecular test. So this could have been totally missed. So karyotype is always better because you cannot definitely say for sure there will not be any abnormality. Microarray was ordered because this was before the law of 24 weeks came, and parents also wanted to know what can happen to the child. Here we could say that extra segment is only going to give you lot of abnormalities, but we cannot say exactly what. And microarray gave us the answer saying that it could be developmental delay, intellectual deficiency, behavioral problems, and distinctive facial features. Pregnancy was, but law had demanded, court was not ready to accept because abnormalities were not mentioned. Now the next, I already discussed about Pallister-Killian syndrome, so we can skip that. Now in Down syndrome, there are different types of chromosomal abnormalities. Now you can have extra 21 in the form of free trisomy or a translocation. The implication is because for patient 1% is 100%. Sometimes in Down syndrome, now by microarray, there is a suppose a phenotype Down syndrome child is there, completely having the Down syndrome phenotype and karyotype comes normal. We can check if there is any partial trisomy which is detected by microarray. Now for parents, it is always advisable to have parental karyotype, types of karyotype. So recurrence risk will depend on that. Now, as you can see, 1421 from father, it is recurrence is 8%, mother it is 14%, and very low grade mosaicism, if it is there, recurrence risk is also low. But if parent is a carrier of GG translocation, recurrence risk is 100%. We have got cases where IVF was done and without doing parental karyotype, repeatedly 2 times Down syndrome babies were born. So it's very important. Now in NIPS, we got this fish 22q deletion syndrome, and the lady earlier had chromosome 21 in the fetus. Now micro deletions, though individually rare, can be collectively more. And maybe so we said we want to confirm this by amniocentesis. Lady was not ready to do invasive procedure as there was no USG marker. But we just explained to her and they agreed. And on amniotic fluid, without having any cardiac anomaly at that gestation, 18 weeks we could see. As you all know, even best of the best ultrasounds or 20% of the cardiac anomalies are missed. Now, actually, because she followed it, that could be solved. Now, this case is of a grandfather having bilateral clubfoot, and he was very keen because his granddaughter's, his daughter-in-law's ultrasound was showing polyhydramnias and only CTV because he suffered because of his clubfoot being a farmer. He said, I want to find out, but just on the for the clubfoot, you will not terminate the pregnancy. We wanted to do karyotype, and surprisingly, there was a duplication of chromosome 12, and then this could have been definitely pathological. So only on that basis we could. Resolving problem in prenatal karyotype is very important. Common trisomies 13, 18, 21. You can have clear prognosis. There is clear prognosis which is bad. In sex chromosomal abnormality, it can be hypogonadism, uncommon hypogonadism, and low IQ, or there may not be any IQ. Now, such you get in prenatal diagnosis. Very difficult to say because we have got intellectuals also who are Klinefelter, and we can have individuals who are also intellectual deficiency. So this clarity, I mean, giving them this clarity when you receive a report of sex chromosomal abnormality is very important, and you take a consent that both have been explained, pros and cons. Of course, we confirm on ultrasound also if there is any ambiguity without telling the patient. Uncommon trisomies, as I explained, it's only tissue mosaicism. Confirmation by further test, amniotic fluid or blood. Translocation, again, depending on consequences, will be the consequences will depend on combinations, and evaluation of parents is very important. So also in marker chromosome, what we have described before. I think we can go to the next evaluation. This is what I was talking about inversion. Now look at this left-hand side. If your fetus is showing inversion of these chromosomes, high risk of unbalanced chromosomal recombinations. So you have to also refer to the literature. We also always refer to the literature in order to doubly confirm or something new has come. Then also, see, there is a low risk if there is inversion 1, 2, 5, 10, Y. And this pericentric inversion with this extensive heterochromatin material on chromosome 9 is absolutely common and harmless. So it's very important you distinguish and find out which chromosome is involved, and there can be intellectual deficiency as well. In molecular testing, when you refer patient, I mentioned that you will send for a molecular test only, but if it is mainly for if the karyotype is not done. Now you can see case number 3. The patient came for thalassemia prenatal diagnosis. We did karyotype and there was X2 translocation. So these kind of abnormalities can be detected. Again, now case number 6 was for thalassemia and there was 1121 translocation and there was also plus 21. So this was came for thalassemia Down syndrome. Again, a young couple. That means age was 32. You can get atypical cases as mentioned here. Each time there was a different chromosomal abnormality. There was a different phenotype. So first was like small stomach, karyotype was and esophageal atresia, everything was normal. Second, missed abortion. So different labs gave different report of DMT, QMT. On NIPT, first reading, no report, and a repeat again was done. It was showed trisomy 18, 1:20. Amniocentesis were done, and in spite of this finding, 20 cells showed 45X and 03 isodicentric Y chromosome. Important to know that isodicentric Y chromosome, of course, genetic evaluation of the couple was normal and karyotype and microarray, clinical rhizome, everything was normal. And fourth pregnancy was normal baby. But in isodicentric chromosome, if they decide to terminate the pregnancy, chances that baby will have normal genitalia, female genitalia, which could be just, but it may be Turner. You can have clear XY genitalia, but spermatogenesis, such cases is affected, or ambiguous genitalia. And if you see that isodicentric is shown in the with that arrow there. Now, in this isodicentric chromosome, if they terminate a pregnancy and if those sex is not, we do not disclose the sex, but if it is seen on termination, they would say it could be an abnormal child. And look here, we have got a normal child. Very cautious you have to be in such cases. In infertility, autosomal abnormality, you can also get autosomal translocations which are familial, and there can be some kind. This is a new thing which we have found last time. Severe oligospermia. First time we have also seen that on chromosome number 1 at a particular region, if there is any inversion, child can the individual can have oligospermia or oligospermia. Also, your X chromosome, Y chromosome and Y autosome translocation is also one of the cause. So it has to be entire chromosomal studies to be done in male infertility. Sex chromosome structural abnormalities we have seen same as the abnormalities, but in X chromosome I will tell you what are the consequences. Next slide. So here we can see various phenotypes. So you may get patient with primary amenorrhea, you may get with anti-menstruation, or you can there can be spontaneous menstruation. So most important region of ovarian maintenance, primary amenorrhea is on this X deletion XQ13. Now, if what happens when there is a scanty menstruation or spontaneous menstruation, the secondary amenorrhea patients are given and karyotype is not done, the treatments are started and they are not going to respond because it's going to have a typical type of structural abnormality. We all know about what is so extremely important any primary amenorrhea or menstrual disorders to do karyotyping, especially to look at the X chromosome. We all are aware of fragile X syndrome. They menstruate spontaneously, secondary amenorrhea, and 50% are infertile. And if you find there is a such case, then you will always tell them if they conceive by IVF or by routine IUI or any other method, the couple has a chance of getting an abnormal. Very, very, very interesting case. This also was last week. I think primary amenorrhea case. There was sex chromosomal mosaicism, but there was also translocation between 5 and 9. It would have been a live audience. I would have put the question, how will you counsel this patient? She was 15-year-old. There was no need to, I mean, we had a definite diagnosis for the cause of her primary amenorrhea. amenorrhea. But as a geneticist, it is our responsibility to tell them that if there is 5-9 translocation, it may not affect you in anything because chances of you, we don't tell directly, but this is between the doctor and the referring physician and the lab. Because of this translocation, we have to give advice for our other family members, because if they are otherwise normal chromosomally, sex chromosomally, and parents translocation, the other progeny can get. So from one can be having translocation, giving birth to abnormal children. So that also we have to explain. We have premature ovarian failure, we are all aware of. Last time we have discussed in details, and I have already told you it's very important. In pediatric cases, most important I will say is about ambiguous genitalia, because need for gender assignment, birth registration is referred. Gender, and this is the emergency in cytogenetic laboratory, because priority of fish, because they are, that is the first thing they have to answer, kya hua, delivery hogi. What are you going to tell them? So we take this as priority, and same as the Down syndrome, but at least there will be able to assign they can assign the sex by external genetics. What is important in ambiguous genitalia, once you assign the sex, the emergent assigned the sex, there are various autosomal recessive and dominant syndromes also associated with ambiguous genitalia, and these some intersex conditions can appear at birth. So multidisciplinary approach is required. Next. Microdeletion syndromes, I will just mention the list here because this is totally a pediatric thing. But what we have to remember in microdeletion syndrome, that recurrence risk is theoretically nil. But I always tell patient, when I tell you 1%, it is 100% for you. They have to take a call that if they have to do it for what they want to do it for this 1% recurrence also. Or gonadal mosaicism can be there. Some like Karyotyping syndrome can also have a karyotype reciprocal translocation in the parent. So parental translocation is all parental chromosomal advice is very important, and the decision of prenatal diagnosis can be. We can just go Digeorge is seen very commonly. Genomic imprinting syndrome, Prader-Willi Angelman. Again here recurrence risk is 1%, but this patient which is seen here Angelman syndrome. Those days we were not doing tests, were not available in India. It was 1% recurrences where couple wanted it. We had to send sample to Germany. Of course, baby was normal. We knew 99%. Now, sex chromosomal abnormalities in female, again very difficult. We know about testicular feminization. So it can be familial also, in spite of having 46XY. Familial in them, more than one person affected. Again, sex determining region on Y chromosome, whether it is functional Y or not, you will know by SRYG study. Now you can, we have to tell, like in Klinefelter, I told you that it is possible that person can be normal or person can have intellectual deficiency as well as reproductive system organ development defect. Here now, our first patient was economist and had repeated abortions. Here trisomy X. Similarly, there are cases where trisomy X can also have mental subnormality. Now, the thing is that now these things are very, very dicey when you get the prenatal diagnostics report. What are you going to tell? Because we have to be very careful in giving such kind of reports without telling them what can happen. And especially prenatal diagnosis is a very delicate area. And all of us must take opinions from fetal medicine experts or your geneticists from where you have referred the lab. In conclusion, I would like to say chromosomal anomalies is the most common cause of genetic disorder. Don't go jump at the newer disorder, newer conditions which are newer tests which are available before doing karyotype. Preconceptional genetic counseling, family history, prenatal screening tests can pick up high risk cases. You remember we have identified by way of family history in version X, and we could prevent and do the test in that pregnancy. Identifying a cause of index case evaluation, parental karyotype, health recurrence risk, and early prenatal diagnosis and risk to family members. I want to add here, whenever we are talking about, this is my thought which has come with the risk of termination. I think it is confirmed that we can do up to 24 weeks now. And earlier now we were all jumping on to karyotype. So it's like a pendulum. From amniocentesis, we went to CVS. But because of the certain limitation, maternal cell contamination is more likely, mosaicism more likely, and we can now also wait a little and get a easier and better, more than expert fetal medicine, even obstetricians are doing amniocentesis. Maybe I'm thinking that pendulum might switch again to amniocentesis because 16 weeks you test, you have got good 8 weeks ahead. Now, DNA storage of the index case child or fetal or POC is mandatory. We tell every patient because later on earlier reports are showing normal, but like achondroplasia or some abnormalities come at later in gestation because beyond second trimester or early third trimester you may not be able to find out. On ultrasound achondroplasia, then stored DNA can come to our rescue to find out the any chromosomal, not chromosomal, any molecule testing, like in achondroplasia, FGR gene mutation, just like one example. Tested at accredited labs, please, because you have to save yourself from, I showed you what the law looks into. Pre-test post-test genetic counseling is an inseparable part. Informed written consent is recommended in all cases, and we all have to remember most genetic disorders are not treatable, but today almost all are preventable. Thank you very much, and thank you for the opportunity for sharing my thoughts, views, and cases with you.
Thank you so much, Dr. Purandare, for a very comprehensive lecture. We have some questions which have come up. Maybe I'll just ask you a few, and then the rest we can take after the second talk. So the first question from Emily Banerjee is, what is your opinion regarding PS plus and H plus in different chromosomes and RPL?
PS plus, answer. Thank you, Nantana. The second or now answers? PS plus and H plus, no?
H plus, yeah.
Yeah. See, these satellites and the extra markers which are there, those are supposed to be harmless. In earlier cases, when we were new in cytogenetics, when we started, it was like satellite association, they used to say is the cause of chromosomal abnormality in products. So if it is there, we always say parental karyotype to be done because if there is something else which can come up. This you asked about products, no?
Yeah. So what's the connection between that and RPL is the question.
A repeated pregnancy loss. Okay.
Yeah, yeah.
No,
RPL.
I'm sorry. So repeated pregnancy loss, no, I wouldn't say it, but as I said before, if there is a satellite association, when you see a full metaphase, and you can see if there is extra stock there, and there is satellite association, so these can be taken as normal variants. Then satellite association have more tendency, but recently I have not seen any report. But earlier practices, that was one of the causes given for RPL with chromosomal abnormality. Yeah.
Okay. So the next question is, when mosaicism is missed by chromosomal microarray and how?
We have that slide. No, if it is missed, then what to do? What is the question? Can you repeat, please?
The question is, when maybe they are asking about what percentage below which it is missed. What mosaicism is missed by chromosomal microarray and how it is missed. So I think please go ahead. Yeah.
So mosaicism is missed. Now it is a technological thing because I think like you say you do many NGS tests, but you are not able to detect chromosomal defect. You agree with me, Dr. Priya?
Yes. See, because there is a threshold for microarray. Yes. There is a threshold below which, like I would say, 20%. Yeah. So 20%, below 20%, you can't actually identify it in chromosomal microarray, but above 20%, we should be able to tell that it is a mosaic in microarray. But if you want to understand mosaic, I think Dr. Purandare will tell you which is the best test, when you come across it. Yeah.
What was the next?
Sure. I think like
why mosaicism in microarray below 20% is not, we are able to
detect.
So that is a threshold. Yes, that is a threshold. Yes.
Yeah. So that is the limitation of the microarray.
Yes, technology.
Yeah. So maybe let's go to the next question. When mosaicism chromosomal abnormality is missed by chromosomal microarray, I think it's the same question. So if it is very low level mosaic, like if it is less than 20%, then a chromosomal microarray does not pick up. Okay, so that is one possibility. Now the next question is, what is Pallister-Killian mosaic syndrome?
Now about this question, I don't think we showed that case. We had one couple of infertility. The man came saying that almost panicked, and then he was asked to take colostrum because there was a presence of microchromosome. Now we found out microchromosome on karyotype, and we said let's see what is this microchromosome and microarray, what more can we get? But it was not detected in mosaicism. The reason could be the same. Because the answer was you can give it better because you are into microarray. But multiple small, I couldn't say fragments, but pieces of whatever you want to say, sections of chromosome, when they are separate and they come collectively together, you can find out in karyotype, but not in microarray. So we advised, and we also took opinion from Medgenome also. For this particular patient, the same, his forms can be used, but they should think about PGS.
Right. So one other question from Mr. Suresh Pajapati. Is it possible when NIPT predicts high risk for Down syndrome and the baby's karyotype and fish is normal?
Yeah, that's possible. Because they would be calling screening test.
Yeah, so actually I couldn't hear you very well. I don't know if everybody else is able to hear. No, if I can take this, let me tell you that, see, NIPT is a screening test, right? So with that, the fetus can either be affected or not affected. So there are several reasons that fetus may not be affected and your NIPT is still giving high risk. So those are called false positives. Okay, so our previous webinar was on cell-free DNA. I mean, if you have access to that, you can go over it and understand this. So it is possible that the NIPT gives you high risk for Down syndrome, but then the baby may be normal. So that is possible. It's called false positive. So the chances is very low. It's about 0.3%. Let's go to the next question. In case of POC, should we ask for karyotype or QF-PCR?
I would always go for karyotype because you will get all range of chromosomes, including structural abnormalities.
Yes, so that's a very clear answer. And maybe those are the questions for now. We will go on to the next speaker. Thank you, Dr. Purandare.
Thank you.
Yeah. So it's my pleasure to introduce the brilliant Dr. Pragna Ranganath. She's the additional professor and head, Department of Medical Genetics, NIMS, Hyderabad. She's also an adjunct scientist, Diagnostic Division, Center of DNA Fingerprinting and Diagnosis, Hyderabad. She has done her both PG and UG in JIPSA, Pondicherry, and also her DM from SDPGR, Lucknow. She is a member of the Therapeutic Scientific Committee for International Rare Diseases Research Consortium, member of Technical Experts Committee for Department of Biotechnology, Government of India, Executive Committee member of Indian Academy of Medical Genetics and Associate Editor of Genetics Clinic, National Advisory Board member for Indian Pediatrics Journal Committee. She has over 800 peer-reviewed papers, 21 book chapters, and is an editor of one book. And her areas of interest, as you can see, are fetal hydrops, lysosomal storage disease, genetic neuromuscular disorders, skeletal dysplasias. Welcome, Dr. Pragna. We look forward to your talk.
Thank you so much, Dr. Priya. At the outset, I'd like to thank Dr. Mandakini Madam, FOGSI, Medgenome, and the entire organizing team for this opportunity. And I'll be talking on the role of QF-PCR and MLPA in prenatal diagnosis. And I think the previous talk by Dr. Hima ma'am has made a lot of things clear, and it's really made my job a lot easier. So I'll be focusing primarily on QF-PCR and MLPA, the technique and their role in aneuploidy testing, and also their other applications in prenatal genetics. So as ma'am has already mentioned, the rapid aneuploidy detection techniques are primarily used for diagnosis of common autosomal trisomies, primarily chromosome 21, 13, and 18 related, and also the sex chromosome aneuploidies. And the primary advantage of these techniques is that they have a short turnaround time of about 24 to 72 hours only. And this rapid detection is particularly useful to allay the anxiety of the couple in the prenatal setting. And also, of course, when the prenatal sampling is done close to the legal limit of termination, it's really helpful to have a report which comes within 2 to 3 days. And also, as mentioned by ma'am again, in disorders of sex development, where the newborn has ambiguous genitalia, it is very helpful for quick gender assignment. So the three main techniques which are used for rapid aneuploidy detection are FISH, QF-PCR, and MLPA. And I'll be talking about QF-PCR and MLPA in my talk. So what's QF-PCR? QF-PCR stands for Quantitative Fluorescent Polymerase Chain Reaction. So this is essentially a type of multiplex PCR where amplification of highly polymorphic short tandem repeat sequences is done. And the primers used for this PCR are labeled with fluorescent probes, and these labeled PCR products are separated through capillary electrophoresis, and the number and height of peaks is analyzed. So what are STRs? Now these are also known as microsatellites or simple sequence repeats. So these are nothing but short tandemly repeated DNA sequences with a repetitive unit of about 2 to 6 bases. For example, you could have CA repeated multiple times at a particular STR locus. So these are highly polymorphic. So what do you mean by this? This means that the number of repeats of these repeat units, repetitive units at a given genomic position or locus as we call it, would be quite variable from one individual to another. So for example, you can see here at a particular locus, let's say we have in the father on one allele, there are 8 CA repeats on one allele, 11 on the other. In the mother, there are 9 CA repeats on one allele and 13 repeats on the other allele. And the child gets 1 allele from the father, 1 allele from the mother. So the child has the 9 repeat allele from the mother and the 11 repeat allele from the father. So the commercially available kits which are used for QF-PCR for aneuploidy detection are mainly the Divisor kit, the AnuFast kit from Imagen, and the ChromoQuant kit from Cybergene. Now, how is this QF-PCR done? So the first step, of course, would be DNA extraction. And in the prenatal genetic testing context, you would be extracting the DNA from the prenatal sample, either the amniotic fluid sample or the chorionic villus sample. And then the PCR is done with the fluorescent labeled primers, after which capillary electrophoresis is done for separation of the PCR amplicons. And for capillary electrophoresis, you use the same instrument, which as is used for Sanger sequencing. So the software which are used for analysis, GeneMarker is one of the most commonly used software, and the other ones include GeneScan, Genotyper, and GeneMapper. So this is what the output looks like, and this is called an electrophotogram. Now, how do you analyze this? So mainly you look at the size, the height, and the area of the peaks. The size represents the length of the amplicon in base pairs, and the area and the height are actually values which measure the fluorescent activity. And the height and area of the peaks in the electrophotogram is actually directly proportional to the amount of the fluorescent products, which in turn is directly proportional to the amount of the target sequence in the sample. So by looking at the peaks, you're able to infer as to whether there is an extra copy or a lesser copy of a particular locus and thereby of the chromosome. So in normal disomic individuals, you expect 2 copies of the chromosome to be there. One would be the maternally derived allele, the other would be the paternally derived copy. So usually the number of repeats would be different in the maternal and paternal alleles as was shown in the previous diagram. So in a normal individual, you will get 2 peaks with a 1:1 height ratio, one corresponding to the maternally derived allele with a specific number of repeats and the other corresponding to the paternally derived allele with a different number of repeats. In trisomy, there should be 3 copies of the chromosome. Now, these 3 copies can exist as 3 different alleles with 3 different numbers of repeats, and these would be in the 1:1 ratio as seen here. So if you get this pattern, it's called a trisomic triallelic pattern. Or sometimes two alleles could have the same number of repeats and the third allele could have a different number. In that case, you would get two peaks, and that would be in the 2:1 height ratio. So this is called a trisomic diallelic pattern. So, but the problem is that when the alleles are homozygous, sometimes both the paternally and maternally derived allele could have the same number of repeats. In that situation, the STR marker, that particular locus, could be uninformative. So this can happen especially with consanguinity. So when the parents are related, both of them could have the same number of repeats at that particular given locus. And of course, it could happen without consanguinity also. So therefore, because some of the markers could be uninformative, you need to use more than one STR marker for each chromosome. If you were to use only one marker per chromosome, you could get such uninformative results. So this is an example of the ANUFAST QF-PCR kit, where you have about 36 different markers corresponding to the different chromosomes. So what is the utility of QF-PCR? So the most important utility in the prenatal context is, of course, in rapid aneuploidy detection. And you can do this within 24 to 48 hours and release the report. And this has close to 100% specificity and sensitivity for detecting the sex chromosome aneuploidies and the common trisomies. Of course, some studies have reported slightly lower sensitivity of about 95 to 96%, but majority of the studies agree upon this 100%, close to 100% figure. The other important advantage is that it can detect mosaicism as low as 15%. And also it has this additional advantage of being able to detect maternal cell contamination. So maternal cell contamination is something that has to be ruled out in all prenatal samples. So whenever a prenatal sample is taken, you first extract the DNA. The maternal blood is always sent to the lab. So the maternal DNA STR marker pattern and the prenatal sample marker pattern is compared. And this is what you should get normally. When there is no MCC, you see that the mother's pattern and the baby's pattern, the fetal pattern, there's only a 50% match. Only one set of alleles should be matching because the other's allele in the fetus is supposed to have come from the father. So this is what you should see in a negative MCC report. But if there is a positive MCC, you could see the maternal allele pattern only in the fetal DNA and also some additional peaks corresponding to the other allele which has been derived from the father. So QF-PCR helps you to additionally look for MCC also. And of course, the other important advantages are that it requires less technical expertise when compared to FISH. And because it is a DNA-based test, it does not really require viable cells. And it can be done easily as an adjunct test to rule out common chromosomal aneuploidies in all prenatal DNA samples collected for other indications. You could be collecting the test for, you could be doing the prenatal sampling to test for thalassemia, SMA, any other monogenic disorder. And when you have the fetal DNA available with you, in addition to doing targeted mutation analysis for the specific monogenic disorder that you are looking for, you could also use the DNA for QF-PCR to rule out these common chromosomal aneuploidies. So this is what a normal electrophoretrogram pattern would look like in a normal female baby. So of course, as per the laws, sex determination is not permitted, and this would the sex related information would not be displayed in the report given to the patient and even to the clinician for that matter. But the lab would be able to see this and analyze whether the number of sex chromosomes is normal also, in addition to the autosomal numbers. So this you can see there is a normal disomic pattern of markers for all three sets of chromosomes, 13, 18, and 21. Then only the X-specific product of the AMXY thing is present here. The SRY is absent, and the X-linked markers are present in 2 copies. And then there are certain markers which are present in the pseudo-autosomal region. Now, pseudo-autosomal region is actually, these are regions which are common to both the X and the Y chromosomes. So if the normal complement of sex chromosomes is there, whether it is XX or XY, the pseudo-autosomal marker should be present in a normal disomic pattern. So all of these boxes are ticked. So this is a normal female pattern. Now here you can see there is one a peak corresponding to the AMXY from X and the other from the Y. And then the pseudo-autosomal markers are present in 2 peaks. The X-linked, X-specific marker, only single peak is there. The 21, 13, 18 markers are all present in a disomic pattern, and SRY is present. So this is a normal male complement. Now here, if we see the markers which are corresponding to chromosome 21, there are 3 copies, that is, there is a trisomic triallelic pattern for one of the markers, and for 4 other markers over here, this one, and like the D21S1414, the D21S1411, and also the other 2, D21S1435, and one more. All of them show a trisomic diallelic pattern, which I mentioned before. There are 2 peaks, but one of the peaks is in a 2:1 ratio with the other peak, indicating that there is a trisomy there. And the other 2 chromosomes, 13 and 18, are present in normal disomic pattern. So this represents, this particular electrophotogram represents trisomy 21. Similarly, here if you see, all the markers are present in a trisomic pattern, either trisomic triallelic or trisomic diallelic. So when this is the case, obviously you cannot have trisomy 13, 18 and 21. So this represents triploidy. Okay. So QF-PCR can detect triploidy as well. And then here, if you see, the SRY is absent. You have a single peak corresponding to the AMXY from X, a single peak corresponding to the X-specific marker, and a single peak corresponding to the pseudo-autosomal marker. So this represents, and the other things, the 21, 13, and 18 markers are present in a normal disomic pattern. So this represents a 45X, monosomy X, or Turner syndrome. And here you can see the pseudo-autosomal markers are showing 3 peaks, and there is a 2:1 ratio for the AMXY probe. SRY is also present, and there are 2 peaks corresponding to the X-specific probe. So all of this indicates that this is XXY or Klinefelter syndrome. So of course, in the prenatal context, these would be reported as sex chromosome aneuploidies. Now I'll just take you quickly through a clinical scenario. So this was a 28-year-old primary gravida who presented at 18 to 19 weeks of gestation. The TIFA scan showed bilateral choroid plexus cyst, anossified nasal bone, and complete AVSD. Clinically, actually, we were thinking of the possibility of trisomy 21 here. An amniocentesis was done, sample was sent for QF-PCR and karyotyping. And as you can see, the pattern was suggestive of trisomy 18. So one of the 18 markers has a trisomic triallelic pattern, and the other 2 have a trisomic diallelic pattern with a 2:1 ratio of the peaks. And then karyotype confirmed this. There was indeed trisomy 18 in this particular fetus. So what are the limitations of QF-PCR? It cannot detect structural chromosomal aberrations. And because some markers may be uninformative, you have to use multiple markers for each chromosome. And it requires the capillary electrophoresis equipment, that is a Sanger sequencer equipment, which may not be available with all labs. Now moving on to MLPA. So MLPA stands for Multiplex Ligation-dependent probe amplification. So this is again a modification of Multiplex PCR. So this MLPA technique has been developed and copyrighted and patented by MRC Holland. And whatever probes you have to order from MRC Holland through their specific designated dealers. And this particular test is used for relative quantification of specific target loci. And you can have up to 40 to 45 nucleic acid targets in one reaction. So this is how MLPA works. So each probe set would be like this. There would be 2 oligonucleotide probes complementary to immediately adjacent sequences, as you can see here in this particular figure. For each target locus, there will be 2 probes. One is called the left side probe. The other one is the right probe, right-sided probe. So all probe sets have a common primer binding sequence at their 3' and 5' ends. So these are called the universal primers. And then each probe has something called a stuffer sequence. This is the orange colored thing here, which can vary in size from about 19 to 370 nucleotides. And the purpose of this stuffer sequence is to create a unique length of the ligated probe sequence, so that subsequently when you do capillary electrophoresis, you can actually separate out these different sequences based on their length. So what are the steps of MLPA? The first step is hybridization of the probes to complementary target DNA sequences. Then the ligation of the adjacent bound probes happens. So unless there is an initial hybridization, the ligation doesn't happen. So that means the ligation happens only for those probe sets which have hybridized onto the target sequence. And if that target sequence is missing, the hybridization doesn't happen and the subsequent ligation doesn't happen. And then all these ligated probe sequences are amplified through a single PCR reaction with the universal primer set, which is present on all the probes at the 3' and the 5' ends. And then finally, all these fragments are separated through capillary electrophoresis and analysis. Why not gel electrophoresis? Because gel electrophoresis doesn't have such a high resolution. You need to be able to differentiate between these fragments with even a few base difference. And that would be possible only with a capillary electrophoresis apparatus. So the probe mix which is used for aneuploidy testing is the SALSA MLPA P095 probe set. And this has 36 probes. There are 8 probes each for chromosomes 13, 18, 21 and X, and 4 probes for chromosome Y. And in addition, there are some quality control fragments also. I would not really go into the technicalities here, but these are also included in the probe mix always. And the software used for analysis would be more often Coffelizer or even gene marker, which I showed before, could be used. So the results are analyzed by normalization to normal or even to internal control fragments. And then you compare the peak ratios with the normal control. So the peak ratio of your target sequence of the sample DNA, if it is in a 1:1 ratio with your normal control, it indicates that the copy number is normal. That is to say, you have the normal disomic pattern. Of course, you cannot always have a round figure of 1 for the peak ratio. So the range of 0.7 to 1.3 is generally considered to be normal. Similarly, if you have a heterozygous duplication, in other words, a gain or a trisomy where one copy is extra, you are supposed to get a peak ratio of 1.5:1 of your sample DNA to the normal control. And again, you cannot have a round figure of 1.5 always. So the range would be 1.3 to 1.7. And if there is a heterozygous deletion or loss or monosomy, you expect the peak ratio of your sample to normal to be 0.5. And this can again range from 0.3 to 0.7. So this is what a trisomy 21 pattern would look like. The probes corresponding to the 21 chromosome, the 8 probes are close to the 1.5 this thing value, the peak ratio. And of course, they're above the 1.3 range. So that indicates, and they're somewhere in between 1.3 to 1.7. So this indicates that there is a trisomy 21 here. And what is the utility of MLPA in aneuploidy testing? Again, very useful for rapid aneuploidy detection because it can be done within 48 hours. Also, less technical expertise required. It's a DNA-based test again, does not require viable cells. And it has a close to 100% specificity and sensitivity for chromosomal aneuploidies. But we have to remember that because there is a normalization procedure involved here, it may miss the 69XXX triploidies. And also, it is not a great test to detect mosaicism. It may be able to detect, but the sensitivity is a bit low for detecting mosaicism. And the sensitivity of MLPA to detect mosaicism is not very clearly studied and not very clearly reported. And also, especially in a female fetus, it may not be possible to detect maternal cell contamination with MLPA. And again, it cannot detect structural chromosomal aberrations. And also, as I showed before, it requires a capillary electrophoresis equipment, that is a Sanger sequencer equipment. Then apart from this aneuploidy testing, in fact, aneuploidy testing, it's less often used for. What it's more often used for is to detect deletion and duplication of one or more exons within a gene. That is to say, for monogenic disorders, which are caused by large deletion duplication type mutations, because sequencing technology, I mean, Sanger sequencing is actually, it can miss heterozygous large exonic deletions duplications. And even next generation sequencing, though now there are software available for NGS data analysis, and depending upon the number of reads and the depth of coverage, you can analyze and determine whether there is a possible exonic deletion or duplication present there. It is still not considered the standard test for detection of these large intragenic deletions duplications, and MLPA would be the test of choice when you want to look for these kind of mutations. And it also helps to detect common chromosomal microdeletions and microduplications. So let me take you through some illustrative clinical scenarios. So here, for example, we have a third-degree consanguineous couple. The first child was affected. This child was brought at 7 months of age with the history of reduced limb movements noted from the 3rd month onwards, had attained only partial head control, had not attained rolling over or sitting even with support. And on examination, though the child's higher mental functions were more or less normal, the child had generalized hypotonia, absent DTRs, head lag when pulled to sit, tongue fasciculations, no hepatosplenomegaly, mildly elevated CPK. So all the features were suggestive of spinal muscular atrophy. And for that purpose, we did SMN1 gene MLPA, because we know that 95 to 98% of cases of SMA are because of homozygous deletion of exon 7 with or without deletion of exon 8. So SMN1 gene MLPA was done for this affected child. And as you can see, there was a homozygous deletion, as in both copies of the exon 7 and 8 in the SMN1 gene were deleted in the child. Therefore, you are not seeing any peak at all corresponding to exon 7 and also corresponding to exon 8. The red one is the normal control and the blue one is supposed to be the patient's sample, the DNA sequence, and that's the peak is completely missing for exon 7 and exon 8, indicating that it is a homozygous deletion. And when the testing of the parents was done, both were confirmed to be heterozygous deletion carriers. So you can see the peak ratio is about 0.5 of the normal, indicating that one copy is missing, one copy is present. So they are heterozygous deletion carriers. And now when the family came to us with this, so this proband unfortunately passed away at 1 year of age. And then the family came back to us with the second pregnancy for prenatal genetic testing. And we have a diagnosis in hand. We have a confirmed diagnosis for the proband, which is absolutely essential when you want to do prenatal testing for recurrence for subsequent pregnancies. So here now the CVS was done at 13 weeks of gestation. And in the CVS DNA, the same SMN1 gene MLPA was done. Fetus was found to be heterozygous for this deletion, and therefore the family was counseled and reassured that the fetus was not likely to be affected. They continued the pregnancy and the baby was found to be normal on postnatal follow-up. Another scenario here of a 7-year-old male child who presented with difficulty in getting up from sitting and squatting position and in climbing stairs, mild delay in walking without support in early childhood, and then CPK was highly elevated. So the clinical diagnosis here is most likely Duchenne muscular dystrophy. And if you look at the pedigree, that is also consistent with an X-linked recessive condition, wherein you can see that 2 brothers of the mother have died with a similar phenotype at 18 years and 20 years respectively. And this is a proband. Now the mother is planning for the next pregnancy. She also has a younger sister who's planning to get married, who wants carrier testing done. So first line test for suspected DMD would be MLPA. Why? Because 65 to 70% of DMD cases are because of large exonic deletions and duplications. I already told you sequencing is not the test of choice when you have a suspected exonic deletion or duplication to look for. So here MLPA is preferred as the first line test, and that is what is done for the proband first. And if the proband is confirmed to have a large deletion or duplication mutation in MLPA, then the same deletion or duplication mutation is looked for in the other individuals who wish to undergo carrier testing. And the same thing is again looked for in the prenatal genetic testing scenario in the prenatal sample. So as you can see here, there was a hemizygous deletion of exons 46, 47, 48, 49, and 50 in the proband. And you can see, we call it hemizygous here because this is an X-linked recessive condition. It's an X-linked condition. And a male individual is expected to have only 1 copy of the gene normally. And if that itself is deleted, that is said to be, the individual is said to have a hemizygous deletion. So this proband is hemizygous for this particular deletion mutation. And when the same thing was tested in the mother and the maternal aunt, both of them were found to be heterozygous deletion carriers. In other words, they are carriers for DMD. So now we know that there is a 50% risk of recurrence of DMD in each male offspring of the mother and also of the maternal aunt. So prenatal genetic testing would be recommended for both of them for all their subsequent pregnancies. And in prenatal genetic testing scenario also, we would be taking the sample either through chorionic villus sampling or amniocentesis, and in the fetal DNA, the same MLPA testing would be done. This is the other scenario where MLPA is used. So here we have a child who presented with developmental delay, facial dysmorphism, failure to thrive, cleft palate, which can be appreciated here in the picture. And child also had a congenital heart disease, tetralogy of Fallot, The clinical diagnosis here was Digeorge syndrome. And we know that Digeorge is caused by a small deletion on chromosome 22q. And usually the deletion is quite small. That's why it's called a micro deletion. It's a bit small and cannot really be picked up through conventional karyotyping. So for these kind of scenarios where you have a micro deletion or a micro duplication suspected, karyotyping would not be the test of choice. Rather, you would go for molecular cytogenetic tests. So that could be the FISH or MLPA or microarray. And here, because we have a clinical diagnosis of Digeorge, you could first do MLPA for that because you have an MLPA probe set for common microdeletions. So you could use that. That works out much cheaper than microarray. You could do that first. And if that itself confirms your diagnosis, as was the situation in this case, you need not really go for any further more expensive testing. But of course, if this had come negative, you would have had to go for chromosomal microarray, because that helps you to look for these copy number variations across the genome. Whereas in MLPA, you can look for only specific target regions for which your probes are there in your probe mix. So to summarize, QF-PCR and MLPA are both quite good techniques for rapid aneuploidy detection. And they score over FISH in that less technical expertise is required for these tests. Both of them are DNA-based tests, so that's another advantage. And then other advantages of QF-PCR include that it is helpful in detection of maternal cell contamination, triploidy, as well as mosaicism, up to even 15%. And of course, both techniques have other applications as well in clinical genetics. So I'll stop with that and maybe we can take questions. Thank you.
Thank you so much, Dr. Pragya. That was a very detailed, very clear presentation. I think it will be very helpful for all participants. Let us know if you have questions. Right now, I don't see any questions in. Oh, okay. So there's a question which is asking you, what is tetralogy of Fallot?
Okay. So that's a congenital cardiac anomaly. And yeah, so in that context, I was also planning to tell that if you have similar congenital cardiac anomalies in the prenatal scenario also, where either in TIFA or in fetal echo, you have detected something like this, especially outflow tract anomalies, then there also you would be suspecting a possibility of Digeorge syndrome. So there, either you go for microarray, and of course, nowadays, probably it's better to go for microarray because the costs have come down. But otherwise, in resource poor settings, or if you do not really have, maybe if the patient wants to go the lower cost test first, you could actually go for this 22q MLPA or FISH. Yeah, so coming back to this question of what is tetralogy of Fallot, so it's a congenital cardiac anomaly associated with cyanosis, and it is associated with subaortic VSD. And you have this, other anomalies involved then, pulmonic stenosis. So, so it's associated, it's a congenital cyanotic cardiac anomaly.
Thank you. There's one other question. I think you explained it. Maybe we will go over again. What is the difference between biallelic and triallelic trisomy? Okay.
So if you would like me to share my screen again, I'll just go back to that slide where I'd shown this. Yeah, so basically when you have this thing, so in trisomy, you have 3 copies of the chromosome. Sorry, just a minute. So yeah, in trisomy, you have 3 copies of the chromosome. Okay, is my slide visible?
Yes.
Yeah,
please go ahead.
As you can see, so as you can see in this figure, here the 3 alleles. So this can happen when there is a meiosis 1 non-disjunction. So you expect the 3 alleles to have different number of repeats. All right. So 2 alleles probably would be from one parent, and the 3rd allele would be from the other parent. And here in the 3 alleles, the number of repetitive units is different. So here you will have 3 different peaks, each corresponding to 1 allele, and each of them would be more or less of the same height. So that's what we mean when we say the peak height ratio is about 1:1:1. So if you get 3 different peaks like this, that's called a trisomic triallelic pattern. Whereas if you get like this, so especially when, let's say, the non-disjunction has happened in meiosis 2. So you expect two alleles to have the same number of repeats, and the third allele, which has been derived from the other parent, to have a different number of repeats. So the two alleles which have the same number of repeats, both of them will produce a peak at the same position, because this represents the size of the amplicon. So in both these alleles, the size is the same. So you will have the peak happening at the same position, but there are two alleles there, whereas the other allele, position, there is a single allele there. Therefore, the ratio, peak height ratio of this is to this will be 2:1. So when you have this pattern, also it indicates trisomy, but you have two alleles only, and therefore it's called a trisomic diallelic pattern. I hope it's clear.
Very clear. Thank you. So basically, both are trisomy itself. It's just because of how the alleles are distributed, you get it this way.
Yes, that's right. So it doesn't, so basically, you should not think that when there's a trisomy, you have to have three different peaks. You could have two peaks with a 2:1 ratio. Sometimes you could have a single peak also when all three alleles have the same number of repeats. In that scenario, of course, you would probably not consider that marker because it would be an uninformative marker.
Right.
Yeah, it can explain the way, like suppose we have three black pens. So we can call them three black pens, or you can have one black pen, white pen, and a blue pen. So three different type of pens. So all three individuals have got three pens, but one is black, one is white, and another is blue. One can have two white pen and one say black pen. So it is one black, and for example, every pen will give a peak. So black pen will give a one peak, and the one who has got one black and two white pen will get another peak, which is double the amount of the black pen, because it has two pens. So that way she has two peak but three pens. And similarly, like three colors will give three peaks. So it can be three different peaks. It can be two peaks with one peak, which is double the amount, or it can be three altogether one peak, but three in triple amount. So this way it can be understood. So that way, this is technology, and then to understand it better way. And I must congratulate Dr. Pragya and Madam Hema to explain it in such simple way. Probably that's the simplest way that genetics can be understood, and then giving lot of time to each subject, like QF-PCR. We probably in a hurry hush manner, we probably use 2 or 3 slides in explaining them. But exactly why it is called as multiple, why it is called as ligation, and what is a probe. So everything is explained so nicely. Even Madam also saw such interesting cases. My God, it's a lot of cases. Even probably it will take years for me to see such nice cases. Yeah,
that's true. So we have 2 other questions. Okay, so one DMD identified with specific deletion. Mother found to be normal for that loci, but she's having miscarriages. What may be the reason?
All right. So as far as miscarriages are concerned, it's not really related to DMD. So there are so many different causes for recurrent pregnancy loss. And generally for early recurrent pregnancy loss, if you see first trimester losses, about 5% of couples could be carriers of balanced chromosomal rearrangements. That could be the cause. And then other than that, in early pregnancy losses, there are no other definite, even though a lot of studies are there, a lot of association studies are there, no other definite genetic causes are clearly identified in first trimester pregnancy losses. Lots of non-genetic causes are there, including Apla syndrome and others. So that would be a separate evaluation altogether. When you talk about mid-trimester, later gestation losses, of course, a lot of other genetic causes could be there, including your lethal skeletal dysplasias, monogenic conditions causing hydrops, and so many others. But it's none of them, this miscarriages is not really related to DMD. And the fact that the mother's DNA is negative for the DMD mutation does not, again, it doesn't have anything to do with miscarriages, of course, the DMD, But if the mother's blood DNA tests negative for carrier status for the DMD mutation, it does not mean that the proband is a sporadic case, simplex case with a de novo mutation always, because the mother could potentially have a gonadal mosaicism for the mutation, which could be there only in a proportion of her gonadal cells. And that would not be identifiable in the blood DNA. There's no other real way to really confirm that. But that phenomenon has to be kept in mind, that likelihood has to be kept in mind. And therefore, even if the mother tests negative for the mutation in her blood DNA, you should still be offering prenatal genetic testing for subsequent pregnancies of the mother for the DMD. But the miscarriages are unlikely to be related to the DMD thing.
Thank you so much. So there's one other question. If MLPA is available, still multiplex PCR for DMD mutation analysis can be used as initial step.
Yeah, so the problem with multiplex PCR is that, first of all, it includes only the hotspot mutations, not all. So it covers about 18 exons, not all of them, whereas we know that there are 79 exons in the DMD gene. It's a pretty huge gene. Secondly, the multiplex PCR test is not helpful for carrier testing, because it will not be able to differentiate. I mean, if a lady is having one copy of the mutation and the other copy is normal, you'll still get the normal product corresponding to the normal allele. You'll not be able to detect her carrier status. So multiplex PCR is not good for carrier testing. MLPA would be helpful there, as was shown in the slide. And then multiplex PCR cannot detect duplication type of mutations, which are picked up in MLPA. It can pick up only the hemizygous deletions in the proband. So these are all the disadvantages of multiplex PCR over MLPA. And of course, both the techniques are not good, or rather they cannot pick up all the other non-deletion duplication type of mutations, the sequence variants, the splice variants, and all the others, the small few nucleotide insertions, deletions, all of them would require sequencing again. There, even MLPA would not help you, but there are a number of advantages of MLPA over multiplex PCR. And the costs have come down quite a bit, and it's quite readily accessible in a lot of labs. So it's better to do MLPA as a first line test rather than multiplex PCR when you have a suspected case of DMD.
Right. There's one other question. In case of prenatal cases of DMD, if a female fetus is identified to be a heterozygous carrier, can it be reported as carrier?
So this would again be a lab policy. So at least in CDFD, it's given as fetus likely to be affected or fetus not likely to be affected. The hemizygous heterozygous thing is never mentioned in the report. So again, I think there would be that would be the lab's policy. I have seen, including I think MedGenome does report heterozygous deletion, or I'm not sure. I think you would be the better person to comment upon that. But in CDFD, the report is given as either the fetus is likely to be affected or not likely to be affected. So if it is likely to be affected, automatically it means that it is a male fetus with a hemizygous deletion or hemizygous mutation. Not likely to be affected could be either a female fetus with a heterozygous deletion, or a female fetus without the mutation, or a male fetus without the mutation, any one of the three. So that way you do not reveal the fetus fetal sex at all.
One thing I wanted to know, I mean, if the parents specifically want to know the carrier status prenatally, is it possible?
So it's a debatable issue again. So nowadays, I mean, including your lab, I do see you mentioned heterozygous, even for the autosomal recessive disorders, the fetal heterozygosity is mentioned in the report. So naturally, there the reasonably well-educated parents would know that the fetus is a carrier there automatically. But again, you know, of course, it's again the lab policy and so on. But we have seen some families who have gone and terminated pregnancies where the fetus was simply a carrier for beta thalassemia, which is actually really bad. So because of that, at least in CDFD, this policy of not disclosing carrier status is followed in the prenatal sample. So it's just given as affected, not affected.
But there are no guidelines or a national policy.
There are no real guidelines regarding this. That's true.
Okay.
That's true.
Okay. Yeah. So one other question, will there be any issues due to revealing the sex in prenatal case?
Yes, of course.
Of course. Yeah.
We have the PCPNDT laws in India, which are really stringent. And so obviously there would be a big issue with sex determination.
We have a series of
has to have a PCPNDT approval before they start doing prenatal testing, and they have to give the undertaking that they would not be doing revealing the sex in their reports.
Plus updating the records every day. Actually, we do that every day.
Yeah, even us.
Yeah.
Even the clinical center has to maintain that on a daily basis and submit monthly records to the district. Yeah.
So there's one more question. What is the use of subtelomeric MLPA?
Okay, so this is again a different probe mix, different from what we use for aneuploidy or common microdeletions or DMD SMA. So each of these things has a commercially available probe mix. Sometimes you can custom design your probe mixes also if you ask MRC Holland. So basically this covers all the subtelomeric regions of all the chromosomes, because these regions are supposed to be gene rich, and the deletions in these regions are more likely to be associated with abnormal phenotypes, especially intellectual disability and multiple malformation syndromes. So previously, though now it's not really used so much, before microarray came into vogue, people were using these subtelomeric probe sets for looking for this unexplained intellectual disability, multiple malformation syndrome phenotypes. And it has about a 5 to 7% diagnostic yield in these scenarios, the ones we call idiopathic intellectual disability and all. But now that microarray is available and the costs have come down, it makes more sense to do chromosomal microarray than do these subtelomeric MLPAs, because again, they do not cover the entire chromosomal regions.
Okay, Joseph, do you find any more questions?
I think there was one more, Dr. Priya. It's about multiplex PCR.
Yeah, this one. In case of female suspected cases, multiplex PCR can be beneficial for deletion detection.
No, as multiplex PCR cannot detect carrier status in females, because they have a normal allele as well, and that will get amplified and it will give you the band in your electrophoresis. So multiplex PCR cannot detect heterozygous carrier status in female carriers of DMD. That's one of the disadvantages, and that's one of the points where MLPA scores over multiplex PCR.
No, what Dr. Piti is asking is, she is asking female suspected case.
Okay, ma'am. Like
meant DMD or she meant any other suspected case. I'm not very sure. Yeah.
All right. So if you're talking about manifesting DMD individuals, now again, there's so many scenarios there. So if it's a 45X Turner who can manifest DMD, because the Turner is again hemizygous for that. Or if you have a rarely homozygous individual where both copies or have the particular mutation, then perhaps yes. But otherwise, there are other reasons like skewed X inactivation and so on, which can result in manifesting DMD. Those will again not be picked up with multiplex PCR. So it would not really be a good test even in that scenario.
Right. So, ma'am, you want to give the concluding remark?
Yeah.
Dr. Mandakini?
Oh, yeah. That's my opportunity to, like, I feel like this going on. But then I thank Dr. Pragya. I always call her Pragya. Her name is Pragya. I know no, that. But
no, ma'am, it's Pragya.
Pragya. It's very difficult to pronounce, but then anyway, very, very easy to understand your talk, unlike your name. But we are fortunate to have her as the speaker, because the way she explains things, this can happen only if the person has understood things very well. We are thankful to the doyen of genetics, the mother of genetics, whatever we can call, is Madam Hema Purandare. I know those days where we used to do bar body to diagnose a case of primary amenorrhea for Turner syndrome. See, the technology has advanced. That day, taking buccal mucosa and then doing a hematoxylin eosin staining of the cell, so that you can look for a bar body in multiple cells. So gone are those days, but Dr. Hema has started from there to till sequencing era. So has seen the genetics being involved. And thank you, MedGenome. Thank you all the attendee to attend it, and then sending me those emails saying that things are good, and to encourage us to have more program like this. and now to have it in a booklet format or a book format or whatever you call it, as a guide or anything one can refer to immediately as a tips. So thank you everyone, and thank you MedGenome for helping FOGSI out to take out all these webinars. Over to you, Joseph.
Thank you very much, ma'am, for those encouraging words. And I just wanted to remind the audience again that this is part one of the two-part series on laboratory genetics. So next week, we will be talking about microarray and more on the molecular genetic techniques like PCR, Sanger, and of course, next generation sequencing. So we have two good speakers lined up for that also. And on behalf of MedGenome, I'd like to thank Dr. Hema Purandare for taking time off from a busy schedule and giving us that very, wisdom-filled talk, and also to Dr. Pragya Ranganath for taking time off and giving a very detailed explanation on the common genetic techniques. And also thanks to Dr. Priya Kadam for moderating this session. And also a special thanks from our side to Dr. Mandakini Pradhan for taking the initiative and helping us conduct this series and this program, and we hope to have more such programs with Madam in the future. So once again, so thank you to the audience for registering and participating in this session, and we've greatly been encouraged by the questions. We look forward to the next session next week, and please look for the invitation in your mailbox. And just a reminder, if you have any questions or comments on genetic techniques, you can write into us at diagnostics@medgenome.com or call us on our toll-free number or visit us on our website at medgenome.com for more information on these techniques and our offerings. So once again, thank you everyone, and have a nice day ahead. Until next week, good evening and have a nice week.
Thank you, Joseph, for organizing it all the time so flawlessly. Thank you.
Thank you, Dr. Priya. Thank you for encouraging me.